topic of posterior uveitis and cataract, and I will restrict only to posterior uveitis, not to pan or anterior. So you have a situation of cataract with active posterior uveitis where you understand the etiology. For example, this is toxo written on the face of it. So treat the posterior uveitis first. Give the specific therapy. Cataract surgery in these cases can be undertaken as soon as the posterior inflammation has responded to therapy. There is no need to wait for 3 to 6 months of quiescence if you are dealing with only posterior uveitis. And there is no need for any preoperative steroids. You have a second situation, you have a cataract and there is a healed posterior uveitis which could be of known or unknown etiology. You could plan a cataract surgery with no extra precautions. Visual prognosis remains guarded and that has to be documented photographically and the informed consent to be taken accordingly. There is no documented study to say that there is a risk of reactivation of posterior uveitis secondary to the cataract surgery. So there is no need to go overboarding with the prophylaxis and putting some funny drugs in the infusion. The third situation is the cataract and there is an undiagnosed posterior uveitis. For example, this young girl belonging to New Delhi Super VIP's daughter had cataract and had posterior uveitis which had been treated with almost every possible therapy. But it was not really responding to therapy. She's young, 25. So what we could see, there was a peripheral granuloma, there is haze due to vitritis as well as due to cataract, and there is this granuloma sitting for which she had received ATT, there was no response, and then she was being planned for drug, another course of ATT. Now these are the kind of the patients you can straight away plan a combined phaco IOL vitrectomy, and I would suggest 27G vitrectomy because that's where you are going to have a closed system. And if you are combining it with vitrectomy, don't forget to put the sutures, no ego involved, because these uveitic eye, even with this small gauge, as you can see in this one, can end up hypotony the very next day. When you are doing combined, do it under air. First take a good vitreous sample which is undiluted, and then of course you switch on to infusion, take the sample, and the rest is actually easy. So this is the post-op. When we did her PCR, she had rifampicin resistant, which was detected. She was treated for drug-resistant TB, and this is the 2-year follow-up, and you can see this granuloma has responded and her cataract is out as well. The last situation is a patient like this, again from our capital, acute retinal necrosis. This 46-year-old male who's a techie by profession, he says he had sudden decreased vision in the left eye at center A, shown, all uveitis workup negative, given oral steroids, no response, developed kind of exudative detachment, and he did give history of viral encephalitis in the past. So when we saw him, he had exudative detachment for sure, which was not truly exudative anymore, because if you see slit, he was developing a detachment, and within 2-3 days, I wanted to give him a cover of acyclovir because it was a very active eye, but within 2-3 days, he developed severe cataract and the detachment progressed, and you can see a seed-like retina. Now, if there is a situation like this is 72 hours later, you can see how quickly everything is worsening. So if there is a situation like this, please do not plan IOLs or anything, because here the aim is very different. The aim is just to save and salvage the eye, get the thing and save the opposite eye with viral. So this one was more of a viral. Patient underwent carsplenolensectomy with vitrectomy, and it was done in a very, very acute phase. So during the acute phase, when there is anterior segment inflammation, posterior segment inflammation, retinal necrosis, don't be over ambitious, don't put IOL, simply do the needful what is required at the moment. So with this, and this is the post-op of the same patient. So conclusion is you customize your surgery as per patient's need, because every size doesn't fit everybody. So, see what is the need of your patient and decide accordingly. Thank you very much.